Hello, everyone. It's Melissa from Gilda's Club, Grand Rapids. So glad that we could come together today on this virtual clubhouse. Hope that we find you well and enjoying your spring. I know I had to put my winter coat back on today, but we're hopeful that it's going to get nicer in these coming days. If you're new to Gilda's Club or new to a cancer or grief journey, we want you to know that we're a free cancer and grief support community. We would love to talk with you and get you connected with us. Our phone number is 453-8300, or you can look on our website, gildasclubgr.org, and just reach out to us and we'll help you take it from there. And if you are enjoying our programs here on Facebook Live, please give us a thumbs up. We always love that. Or if you have a comment or question for our presenter or for Gilda's Club, please just post it right in the postings on this, and we'll make sure that we feed the questions to our presenter today. So, other than that, I think I'd like to introduce our special guest today. We have Dr. Reddy from Spectrum Health Cancer and Hematology Center. Sorry, I said that wrong, not Spectrum Health, Cancer and Hematology Center of West Michigan. And she has studied at undergrad at Michigan State University and then medical school at U of M. And then her residency was in internal medicine at Maryland Medical Center in Baltimore. And then she had a fellowship in oncology and hematology at the University of Michigan. And we're so glad to have you with us. And she currently is at the Center for Hematology of West Michigan. And again, I said that backwards. I don't know why I keep doing that with that title, but at the Lemon Holton Cancer Pavilion. So it's good to have you with us, Dr. Reddy.
Thank you. Thank you for having me. And, our organization at Cancer Hematology Centers of Western Michigan have partnered with Gilda's Club. We have, that we have a philanthropic arm that we really enjoy and appreciate all the support you give our cancer patients. And so thank you for all that you guys do. And so today I'm going to talk a little bit about head and neck cancer. I know that there were a few questions that came in earlier, so hopefully I answer most of them just through what I'm talking about, but if there's anything new or different, or you need to stop me for any reason, please feel free to note it in the chat, and I will try and answer them as they come along.
Great.
So head and neck cancer is quite a rare cancer overall. It does comprise approximately about 4% of all cancers in the US. So that affects approximately 66,000 people a year. And of those patients, majority of them are male, about 48,000, but a good fair amount are females as well. Some of the main risk factors for head and neck cancer are alcohol and tobacco use. And it's just about them exposing carcinogens into the lining of our upper aerodigestive tract, which is what is considered a head and neck cancer. Most of these are what we call squamous cell carcinoma. That's just a description of what they look like under a microscope. So squamous cell carcinoma are the type of cell that you see for this type of cancer. So the different locations that we see this cancer come up are the oral cavity. So that's within the mouth, basically. The pharynx, so as you go back in through the mouth, to your larynx, which is kind of the voice box and where your vocal cords are. And then also you can see some in your nasal cavities and your sinuses. So a lot of times the thyroid cancers will also be grouped in the head and neck cancers, as well as the salivary gland cancers. So like your parotid gland, and that's one of the big ones. But you have several salivary glands that can be involved. With signs and symptoms of head and neck cancer, a lot of times, unfortunately, they can kind of be sneaky and be minimal symptoms like hoarseness in your voice that just goes on for a while. Or a lot of times we'll see people that come with a neck mass while they're shaving, they notice it, or they may have gotten sick and felt like they had their lymph nodes that were swollen after they were sick, but they just never went back down, or things like that. We oftentimes can hear things like that. You can have ulcers in your mouth, like on your tongue or other places in your mouth that seem like they just don't go away, as well as difficulty swallowing or pain when you swallow foods. If you're finding that, you've had to change what your diet is just because it's not going down appropriately. Obviously, that can be related to several different things, but these are some signs that it could be related to a head and neck cancer. And then overall to weight loss, whether it's because you're augmenting the way you're eating, or if it's just, you're feeling more tired, you're not having as big of an appetite, things like that can be a little bit of a red flag for something going on. And it could be cancer, it could be head and neck cancer, but something going on. Other things, when someone has these things occur, they usually see someone based on what it is. So a lot of times if you have a swelling in your neck or something like that, you'll probably see your primary care doctor, and they might do a physical exam and notice that you have this abnormal lymph node. Depending on how long it's been there and the severity of it and how large it is, and if it's one side, only one side, or if it's both sides, they might look to see if there's further studies that can be done to evaluate it. Typically, people start off with an ultrasound, which doesn't involve any radiation or anything. It's just putting goop on your neck and looking with a probe, and then they can measure how big that mass is and if there's any concerning qualities about it. If that comes back where they're a little bit nervous about it, oftentimes people will get a CT of the neck. So that's a scan that we get to see if, how many lymph nodes might be involved or if there's anything else. Other things, like when you have the mouth ulcers or things, a lot of times the dentists are involved. People will go see their dentist because they've had this sore on their tongue forever, or even possibly sometimes when they go to their regular routine dental checkups, the dentist will usually do an exam and do a good investigation of people's mouths to see if there's any concerns for an oral cancer. Following that, a lot of times the dentist can take a biopsy if they see something that they can get at, or they might refer patients to an oral surgeon possibly that could do a biopsy at that point in time. That biopsy will just check, is this cancer? Is this something else? And kind of go from there. Sometimes if it's a very small lymph node that's inflamed or something like that, sometimes physicians, like their primary care doctors or providers, that could be an infection in your mouth or something like that leading to that lymph node. So sometimes people are tried on a course of antibiotics, for example. But if you're noticing that that isn't helping, or, then you should really bring your concerns back to the primary care doctor to say, well, this really isn't working for me. Because a lot of times we'll see people go through several courses of antibiotics and, not have an answer, and then find out later on that maybe they had head and neck cancer. But so those are some ways that we detect things. If there is enough concern for head and neck cancer, oftentimes patients will be referred then to an ear, nose, and throat doctor or an otolaryngologist, just for further workup. And what they do is they're able to take a scope down, usually through your nose or your mouth, and then go down through these other areas that I talked about, looking at your voice box and further down the head and neck system. They are looking for a tumor, because sometimes if you have the symptoms, you can't actually see the tumor, but they can see it with those techniques that I talked to you about, doing a video scope of it, and then they can sometimes do a biopsy right there in the office. Other times, they might refer you to an interventional radiologist, which is different, and they might need to do the biopsy there. But the thing I love about head and neck cancer, and mostly many of the cancers that we deal with, one of the best approaches to dealing with these cancers is what we call multidisciplinary approach. So that involves a whole bunch of people. And in our case, we work with the ear, nose, and throat surgeons. We see in these meetings that we discuss, patients are able to meet the ear, nose, and throat doctor, the medical oncologist, which is me, then the pathologists and the radiologists who actually look at the scans, and we're all able, and the radiation oncologists, we're all able to sit together and look at patients as a whole. The nice thing about those meetings too is we also have great care from our speech and language pathologists that work with us very closely, because patients, oftentimes will come in with problems with swallowing, or potentially as they go through treatment may develop issues with swallowing or speech. And they're a wonderful asset to us with figuring out, working with patients even before surgery to kind of prep them, or after surgery, and or chemoradiation to assess how people's swallow function is, and go from there. We also utilize palliative care. I think a lot of times people it's a misnomer, or they associate palliative care with end of life issues, but really they help with all sorts of things like symptom management from cancer or from treatment, even with nausea, pain, and a variety of other things too. So it's a whole group approach when we treat patients with any kind of cancer, really, but more commonly too with, or more important in head and neck cancer, because there's so many different players involved. Other kind of scans that we get, we oftentimes will get a PET scan before surgeries if we feel that we're going to go ahead and discuss whether a patient will be a candidate for surgery, and or the other mode of treatment, which I'll get into in a little bit, is chemo plus radiation therapy, just to make sure that we are figuring out where this cancer is, if it's just in the lymph nodes in the neck, or if there's a certain spot that's where it came from, or if there is what we call distant disease or metastatic disease someplace else. So commonly head and neck cancers we'll see spread to the lungs. It's mostly the most common, but you can have a lot of different things. And it's hard too, because a lot of patients have a history, or a heavy history of smoking, which predisposes them to other cancers. And so sometimes if we see a spot in the lung, we're not always sure if that's a separate lung cancer or if it's from the head and neck cancer. So sometimes we have to make decisions about whether we treat them separately as two different things, or one thing from the other. Another risk factor.
Can I interrupt you just for a second, Dr. Reddy?
Sure.
And do you find in head and neck cancer that there sometimes are metastases from other kinds of cancer? Like, is this a typical place where breast cancer or other types of cancers will metastasize?
Not commonly, actually. The other thing that we do worry about, depending, is sometimes esophageal cancers. If they're high enough, they're kind of in the similar location. So sometimes you can see lymph nodes that are enlarged from that, but not typically. Other things don't typically go to the head and neck. Sometimes we also have skin cancer, squamous cell skin cancer, that is, kind of lumped into this bucket of head and neck cancer, especially when it's on the scalp or things like that. So we treat that as well. And that's a very different treatment than kind of what I'm talking about today.
Okay.
Going back to, I mentioned the tobacco and the alcohol as risk factors, but now more and more we are seeing increasing incidence of non-smokers with head and neck cancer as well. And a lot of that is usually what we call HPV or human papillomavirus mediated. So, we're all exposed to HPV, and a lot of times our bodies will clear it themselves, but sometimes it can cause head and neck cancers as well. It's also known as P16 positive. Some patients will see that on their pathology paperwork because it's a marker that we look for as kind of a surrogate for that HPV status. People that have this P16 or HPV mediated cancer, head and neck cancer, they tend to do a lot better. They have a very good prognosis. If they have that is a favorable feature. So that's another thing that we might look for in the diagnostic testing. Outside of the ultrasound, the PET and the CT scans I talked about, sometimes, especially for the nasopharyngeal head and neck cancer, so in the nasal cavity, we oftentimes will get an MRI because it's easier to see things like soft tissues and differentiate if the cancer is eroding into the bone and things like that with an MRI. So that is also a potential mode of looking at these head and neck cancers. So going back to some of the sites which the the head and neck cancer can come up are, like I said, the oral cavity. That includes the tongue, or the front part of the tongue, and the base of the mouth, and the hard palate. So the hard palate's kind of on the roof of your mouth, that hard section. That's why it's called the hard palate. And then your gums, so like your upper and lower gums, that would be considered, and your lip, like the inside part of your lip, is what we would consider oral cavity. The pharynx, and it's hard to describe, but it's kind of, the pharynx has three different parts to it. It's the nasopharynx, so kind of this bit inside kind of your nasal cavities and back further. And the oropharynx, so that's kind of behind where your oral cavity is. So those are the three sections. And then lastly, what we call hypopharynx. So that's kind of lower down the upper aerodigestive tract. And then the larynx, I think I mentioned before, that's kind of where your vocal cords are. There's three different sections that we have to that. And it's supraglottic larynx, glottic larynx, which is where the vocal cords are. And then below that, the hypoglottic larynx. So, and then we talked about the nasal cavity and the salivary glands as other locations. The location is very important because it helps kind of determine how we treat them in some ways. The other thing that helps determine how we treat these cancers are based on the stage, or if it's localized, or if it's more advanced. Mm-hmm. So the thing about head and neck cancer is it's not similar to other cancers where stage 4 means, usually stage 4 means incurable or unable to treat with curative intent. And that's different in head and neck cancers because you can have stage 4 disease. So patients can be diagnosed with stage 4 disease, however, still be able to have a good outcome as far as be treated with curative intent. We don't consider that necessarily as metastatic in the same sense that we would like breast cancer or lung cancer or other things like that. Okay. So stage 1 or 2 head and neck cancers, approximately 30 to 40% of patients present like that. And the 5-year overall survival for those patients is very high, it's 70 to 90%. And a lot of the factors that go into that are just based on how patients present as far as are they that P16 or HPV positive, because that's on the upper end of that, versus if they're P16 negative or things like that. The other parts of that are the treatments for the localized cancers tend to be more surgical or potentially radiation therapy alone, versus the more locally advanced stage 3s, stage 4s, usually involving more lymph nodes in the neck and things like that, are treated primarily either with surgery if it's apt for surgery. So if the surgeon thinks that they can get all of the cancer out, and have what we call clean margins, meaning there needs to be other tissue around it that they can take off, saying, okay, we have this amount of normal tissue, so we know we got everything out, versus chemo and radiation. Both of these are trying to cure patients. Both these methods are trying to cure patients of the head and neck cancer. However, that's where these multidisciplinary conferences come into the play, because what we do is we're in the same room as all of these other specialists, and they give us their expertise on whether or not that they think they could perform the surgery safely. And then more importantly, what is going to be the outcome as far as, is this the best way to get rid of this cancer? And then is this the best way to make sure the patient doesn't have that many lasting side effects from the treatment? So, if they have a ton of voice dysfunction, or, we want to try and do what's best for each patient. And then that speech and language pathologist gives their input as well, knowing kind of where patients are at before they start even. Sometimes during treatment, especially with chemo and radiation and with surgeries, we have to have a feeding tube placed in people's stomachs, because during chemo and radiation, or post surgery, people might have a lot of trouble swallowing, whether it's due to pain or just kind of the anatomy and how things are healing up. And so we want to make sure people are getting adequate nutrition during that time. And so a lot of times we'll say, well, we think it's really important that you have this placed before you start sometimes, or during treatment if we find that patients are losing a ton of weight right away, or they're unable to swallow. And we work very closely with dietitians for that as well. And they can recommend, what kind of tube feeding they recommend for getting enough protein, getting enough, all of those other nutrition.
Sure. Yeah. Okay.
I think that those were the main things that I had to talk about, just kind of overview wise. And if you guys got any further questions in the chat, or any questions you had.
Yeah, I have a few questions from our members that we kind of gleaned from them over the past couple of weeks. And so if there is swallowing, eating, if it's an issue for folks, and if they have had radiation to the neck area, you kind of already spoke to this, but I'll just ask it again. What are the recommendations for dealing with swallowing difficulties, eating difficulties, other than, the placement of the stomach tube? I'm assuming at some point you hope that comes out after treatment is done, right? Yeah.
Correct. Yeah.
Okay.
I mean, the speech and language pathologists really kind of run the show with that, and work with patients with exercises on eating, and then try and identify what the problem is. Sometimes if you had radiation to the neck, outside of what I've already talked about, people can have what we call strictures in their esophagus. So that's outside of the head and neck tumors, but sometimes they might need to see a gastroenterologist to do a scope down the esophagus or the food pipe. and dilate things a little bit so that things can go down easier.
Sure, sure.
But otherwise, if it's more so post-surgery, post radiation or chemo, it's working with those speech and language pathologists. And hopefully, as you're further and further out from treatment, things are getting better slowly.
Yeah.
If they haven't, already.
Yeah. Okay. And I would assume some of your patients are the patients who might have what I think is called a stoma, if they've had the cancer in the larynx. Is that correct?
Yeah. If they have a laryngectomy, yes, they have it all taken out.
Okay.
And then other people have tracheostomies, which is different. And the tracheostomies typically, they usually are able to get those out and they heal.
Okay. All right. So those sometimes are temporary also, like with the feeding tube, the stomach tube.
Tracheostomies, yes. But if you get your whole larynx out, then no, that stoma is permanent.
Okay. All right. Okay.
Yeah.
So that's where the next question is, just coping with possible disfigurement from this kind of cancer and having surgeries and maybe, a stoma or something that's more permanent. Do you have resources for that?
Yeah, so we're very fortunate here at Cancer and Hematology Centers of Western Michigan that we have a clinical psychologist that works with us, and he only sees cancer patients. And so he's very attuned to cancer patients' needs, kind of pre-treatment, just when you're diagnosed, during treatment, and then even actually sometimes the hardest part is survivorship after cancer, being nervous about cancer coming back, and dealing with the side effects of treatments. And so he's great for us and for our patients. And if there's something that he thinks is too much, or there are other problems going on top of the other cancer related things, he is good about referring to other therapists in the area. And I think Gilda's Club, you mentioned, has a lot of support groups and things like that people join for that. And I think maybe you could speak to that.
Yeah. And I will say we've had Dr. Porter on this very show, actually, just about a month ago. He came and talked about trauma, cancer-related trauma, and which is the very thing that often is difficult for people, is that emotional piece, the experiential piece, and maybe they look different, or they feel different, or maybe they have to live life in a different way than they had previous to their diagnosis. And so he spoke to that beautifully, and about how to help adjust to that and heal that emotional wound and move forward. And it is for sure what we talk about here at Gilda's Club. We offer a safe, confidential space that's free of charge, that people can come together with a mental health professional like myself and have a conversation honestly and openly about what that's like to have that cancer experience, what it was like to have surgery, what it's like to live past, in the recovery stage and beyond. And I love that you spoke to the anxiousness of reoccurrence, and that's a real thing. And so we talk about that often. In fact, we were talking about this very thing in group last night, about people looking at us and not knowing how to respond after we've recovered from the initial treatment and surgeries from cancer, and often saying, unfortunately, difficult things to hear, or uncomfortable or awkward, because they're awkward and you feel awkward. And so how to manage that emotionally, and how to take care of yourself is a really important conversation around that for mental health and moving forward in life. And it makes me think about the next question. Honestly, it's a great lead into that, is that do do you have any suggestions or any particular ways that at your center that you help the people who are supporting the person that has the diagnosis, and how they can be most helpful to that person and to you as a team member of this wonderful interdisciplinary team that you spoke of, to move forward with that treatment and afterward?
Yeah, I think that it is very important because obviously our families and our loved ones are what gets us through these, tough times with diagnosis and treatment. And, we don't have anything particularly, but we're always open to having caregivers and loved ones present at all of our appointments. We do very in-depth chemotherapy teaching sessions where you meet with not only the nurse and going over all the chemo side effects and given written documentation, which I meet with patients first and kind of give the broad overview, but for kind of the nitty-gritties and day-to-day things and who to call, what's the number, those kind of things we do at chemotherapy teaching sessions. So in those appointments, they meet with a nurse, they meet with social work, they meet with our financial coordinator. So kind of all the aspects of care. And we highly encourage, caregivers to come to those too. And our social workers do a great job with helping with that as well. So if there is, something going on, I know like we've had, a lot of different situations in, finding caregiver help. For example, I had a patient who was a refugee here and had their spouse in a different country trying to get in, and social work has helped with that and other various situations like that. So, and not in particular, but I think we have a lot of people that are willing to help in whatever way they can.
Yeah, I know that our members often speak of calling their nurse navigator and how important that person is to them, and how even then when maybe their chemo has been cut shorter, like, oh, you don't have to have your last 2 chemos. They're like, but I have to go say goodbye to my nurse navigator. And they really, very important and very helpful relationship to them. And so,
and
very
I think
grateful for that.
Same with our chemo nurses too, because we try and have nurses that are specialized, with different cancers. So they're very aware of the different treatments that we're giving. And we try if we can to get patients with the same nurse each time. And so I've seen a lot of great relationships be fostered with that as well.
Yeah, I would agree. And speaking of that, is that we also here at Gilda's Club have had in the past, and we're getting back to it since COVID, but a mentorship program where we will couple someone with a person who's further out on their experience or journey with the same type of cancer. And so it's a one-on-one relationship, and they can share their experience, strength, and hope, and really hopefully help that person who's newly diagnosed navigate the nuances of this particular cancer. And I know that has been very helpful, especially in the head and neck cancer area. So yeah, we have that available.
Yeah.
Well, great. Yeah, go ahead. Were you going to say something?
No.
Okay. All right. Well, I think those are all the questions that we have for today. And just so grateful for you coming and spending your time and sharing your expertise with us. We are very lucky in West Michigan to have you, Dr. Reddy. And
thank you. I really appreciate it.
Yeah, to have a team the way you talked about, it's really just feels very nurturing and hopeful and helpful. And so just so grateful for that. Yeah.
Yes, thank you.
Yeah. And thank you everyone for joining us. If you have questions, more for Dr. Reddy later, please just let us know and we'll make sure that she gets those questions. If you have wonderings about head and neck cancer for yourself or your loved one, let us know and we'll help you get connected. Or you can just call the Cancer and Hematology Center of West Michigan and talk with them or your PCP directly. Thank you for joining us today. We hope that you all are going to have a great week and we look forward to that warmer weather. Always got to bring that in. And again, if you're new to a cancer or grief journey and you'd like to know more about our free support program, please give us a call 453-8300 or look on our website. You can send us an email, gildasclubgr.org. We have a full both virtual and in-person program happening right now, and we'll be glad to help you get connected. So that's all from us this week, and we hope that you stay well and stay safe. And thank you again, Dr. Reddy, for being with us. We appreciate your time.
Thanks so much for having me and for what you do.
Yeah, our honor. Thank you. Take care, everyone. See you later.